My name is Allison Landolt. I am the president of the Endometriosis Foundation of Houston. We are so excited to have you here with us today for this talk with Doctors um, Thigpen and Dr. Amin. Um, a little bit about the foundation. We are Houston's first and only nonprofit organization dedicated to raising awareness about endometriosis. Our mission has been in process for over 5 years. We started in 2018, got our nonprofit status in 2019. And so we are going into which is really our sixth year as a nonprofit in Houston. Our goals are to raise awareness about this disease, which is so often misunderstood, overlooked, and to help connect patients in our community to doctors who are providing excellent care, doctors who are providing competent care, so that we can break the cycle of delayed diagnosis and ineffective treatment. We are joined today by two doctors in Houston who are providing excellent care to our community. They are going to be talking today about the importance of taking a multidisciplinary approach to endometriosis care in the OR. That is going to involve both complete excision surgery by a gynecological surgeon who is trained extensively in endometriosis, as well as a colorectal surgeon who plays a valuable role in making sure that patients dealing with GI symptoms, patients dealing with disease on the bowel and beyond can get complete excision surgery. I'm going to introduce first Dr. Punam Amin. She is a colorectal surgeon and the director of the Pelvic Floor Health Center at Baylor Medicine. Dr. Amin is double board certified in general surgery and colorectal surgery. She specializes in minimally invasive surgical procedures for benign and malignant pathology of the colon, rectum, and anus. Dr. Amin frequently collaborates on endometriosis surgical cases, emphasizing a multidisciplinary approach to patient care. Dr. Amin is formally known as Dr. Parikh, so you may be familiar with her under either name. Also joining us today is Dr. Brooke Thigpen. Dr. Thigpen specializes in complex gynecological conditions like endometriosis, chronic pelvic pain, and fibroids. She is an expert in excision of endometriosis, hysterectomy, and myomectomy. She prioritizes minimally invasive approaches, including laparoscopic and robotic surgery. Committed to patient centered care, she fosters a welcoming environment and emphasizes shared decision making to align treatments with each patient's needs. Okay, thank you so much for joining us today, doctors. I'm going to go ahead and turn it over to you. We are going to have two portions of our talk today. There will be the lecture portion, which we will record, and the Q&A portion, which we will pause recording. So thank you so much for joining us, and take it away.
Great. Thank you, Allison. I'm Dr. Thigpen, and as Allison had mentioned, I'm over here at Texas Children's Pavilion with Women, which is also with Baylor College of Medicine. And part of my focus in my practice is endometriosis excision. So I wanted to start our discussion today just with a couple, common topics that involve endometriosis, the surgical approach, some of our workup, and also how we kind of make a decision whether or not to involve colorectal surgery in the management of your care. Okay. So the first thing I wanted to talk about is what exactly endometriosis excision surgery is. So more traditionally, and previously in the past, endometriosis was managed with ablation or fulguration of these lesions. And so you can see here on these images, these are pictures on the left showing two different patients with endometriosis. And so these are your pretty typical lesions that we may see at the time of surgery. And you can see both of these, this top image here, these lesions are kind of located on the back side of the vagina and close to the rectum. And so when these areas are closely located to some of these vital structures, fulguration or ablation may not be effective in treating it because we don't want to damage any of these vital structures nearby. And then additionally with excision, we're really able to get in there and remove the entire disease, whereas ablation or fulguration may just get what's on the surface. And then this image here on the left, that's on the lower part here, is showing another area. This is more of a deep infiltrating lesion. So it's growing a little bit deeper into the sidewall of the pelvis, and it is right on top of this patient's ureter here on the left. And so with excision, we're able to, again, really get in there and remove all the endometriosis. And this is something that you wouldn't be able to completely treat with an ablation. And so now you can see here the images on the right. This is what it looks like after the endometriosis has been excised. So with the surgical approach, I personally do this robotically. I would say, at least all the partners in my practice, we all do our endometriosis surgery from a robotic approach, which is a version of laparoscopy. And some people may also do this laparoscopically. But essentially, we're able to basically peel off the lining of the pelvis. That's called the peritoneum. This is almost like I say, a good analogy is like it's the skin of the pelvis. And so we really peel off this layer to be able to get all the endometriosis lesions. And then sometimes there may even be areas that aren't as obvious. And so with an excision, you're able to get some of the areas that you may not see directly. So at this picture on the top left as well, you can see, so these brown black spots, these are kind of the typical classic endometriosis we may think of. But then this image here, in the same image to the right, you can see these almost white little spots here. These are almost blister-like lesions, and these may not be as obvious, and some people may not recognize that this is actually endometriosis. And so with excision, you can remove this as well. And so again, this is close to the patient's rectum. It's more on the back side of the vagina, but able to peel all of that out to completely excise. And then the same thing here in this bottom image. This is on the left side wall of the pelvis. And you can see underneath this peritoneal layer, there's all these important, vital structures that you want to be careful. And so you can see some blood vessels. You can also see the ureter, which is part of the urinary tract that goes from the kidney to the bladder. And so we want to be careful to avoid damaging any of these structures with the surgery. And so with this surgical approach, you're able to carefully remove all the endometriosis while also avoiding any damage here. And then, also, I think what's different about this surgery is, again, with general OBGYN training, most of us are not taught how to do this type of surgery. So that typically does require additional training. So for me, I did a fellowship in minimally invasive surgery, and a big focus of my fellowship training was learning how to do this surgical technique. And I would say that was majority of my training was learning this. And again, not everyone who does a minimally invasive surgery fellowship necessarily learns this technique. Every program is a little different in what they emphasize, but that is definitely something to look for when you're deciding whether or not to have surgery for endometriosis. And then as far as other benefits to excision surgery, it's just a little bit more effective for long-term disease management. And so I tell every patient, endometriosis is a chronic disease. We do not have a 100% cure for this. Even a one-time surgery is not going to make your endometriosis completely go away, but our goal is to, remove as much as possible at the time of surgery. And this is going to help improve long-term outcomes and decrease the chances of it coming back later on in life compared to just typical ablation of endometriosis. Recurrence of endometriosis is another common question I get a lot. So, what is the chances of this coming back? And I think recurrence is, it's kind of a difficult topic to approach because a lot of times it does depend on the original surgery. And so was the first surgery, was endometriosis completely treated? So was it completely excised? If it was not completely excised, then it's not necessarily that the endometriosis recurred afterwards. It's probably that it wasn't completely treated the first time. But with complete excision, the chances of recurrence, again, we generally quote, and again, the data and the studies to look at this are overall not great because this is a somewhat newer surgical approach. But in general, I tell patients it's about a 30% chance of recurrence over about 5 to 8 years, and that's with a fertility sparing approach, so without having a hysterectomy. And again, that's always going to vary from surgeon to surgeon and the severity of disease at the time of surgery and also the approach that's taken. And then another common topic I want to also discuss is the MRI of the pelvis. And so we typically recommend this for our workup of all of our patients. And so it's important to emphasize that the MRI is not used to diagnose endometriosis because even superficial lesions are not going to be picked up on your MRI. MRI is most important for surgical planning and being able to determine if there's endometriosis on the rectum or on the bladder to help make a better surgical plan leading up to surgery. And so I never use the MRI result to say, oh, this is because of this result, you need to have surgery. The MRI is not to make the decision for surgery. It's more to help with the surgical plan, if that makes sense. Because I've certainly have scenarios when a patient has an MRI done, it comes back, quote, normal, we don't see endometriosis, but then we do go have surgery because the patient is symptomatic and we still find disease at the time of surgery. And so what we do here at the Pavilion for Women, which is our women's hospital associated with Texas Children's, is we have an endometriosis protocol that we use to help us evaluate for endometriosis better. And so we use a contrast gel. And so the gel comes in a syringe when you go for your MRI. And this gel is placed in both the vagina and the rectum. And so I tell all patients this before, at the time of their initial consultation, before their MRI, because obviously this is not, your standard MRI. It can be uncomfortable, allow you to mentally prepare for this a little bit. But there are a lot of benefits to using this gel. And so it helps us improve our visualization of the spaces that we want to see for endometriosis and helps us to improve our detection rates. And so I just wanted to show here in some of these images, again, this is an MRI. Don't expect, not everyone here is medical necessarily, but you can appreciate a little bit of the difference when you have gel and you don't have gel. And so in these images A and C, this is just your standard MRI where you're not using gel. And so this image C, this is an image looking from the side of the patient. And so you have your uterus here, and then these two places is where the rectum and the vagina are. And so here without the gel, it all kind of looks like one structure. You can't really see what could potentially be between these two spaces. But then you look over here to image D, and this is where there's gel in the vagina and rectum. And that gel allows the vagina to light up this white color. And same thing here, the rectum is white. And with that gel, now you can see that there's a nodule between the vagina and the rectum, which previously was not seen well without the gel. And so that's part of the benefits of using this is it helps us detect our rectal lesions better, any lesions that are between the rectum and the vagina. The gel can only go up so high in the rectum, so it's not really detecting lesions, in the sigmoid colon or, up higher in the colon, but it is better for these lower lesions. And so, and the other, I would say, benefit to our MRI that we do here, as well as that our radiologists are very practiced in reading MRIs for endometriosis. And so that's all they're doing. I would say probably 80% of the MRIs that they read here are looking for endometriosis. And so they're very used to looking for some of the classic signs that we need to see. And so I get asked a lot, can I go have my MRI done somewhere else? And I would say it's not that we, you have to have it done here at TCH, but this is the only, at least MRI facility here in Houston that I have found that will use this vaginal and rectal gel. And so the gel is really the important part of it, and being able to have a radiologist that's going to pick up the correct information, because I've certainly had places, because sometimes there's insurance issues, other reasons why we need to have an MRI done somewhere else. And the MRI may come back not showing anything, and then we go into surgery and we do find there's something on the rectum. And it's always, our goal is to be as prepared as possible prior to surgery. Again, we realize with endometriosis, we can still only have so much preparation based off of MRI, but whatever we can have ahead of time is helpful. That way we can have either a colorectal surgeon or a urologist available. And then, as I, kind of already mentioned why it's important, it's really for surgical planning. And so when it detects these more deep infiltrating lesions of other organs, which are, the bladder and the bowel, you really need either a urologist or colorectal surgeon involved to help with those parts of the surgery. And then how do we decide when to refer patients to colorectal surgery? And so there are a few criteria that I typically use, and I think everyone's practice varies a little bit. But in general, if anyone has had a prior surgery in which, they were told you have endometriosis on your rectum, or they have surgical photos from a prior surgery that do look like there's endometriosis involving the rectum or the colon, then I will send to colorectal surgery. Or there's certain things that the MRI may show. So certainly if the MRI is showing a nodule on the rectum, then that requires referral to colorectal surgery for a combined surgery. And so the goal is for you to meet the colorectal surgeon, to meet Dr. Amin prior to your surgery so that she can discuss, the implications of that her portion of the surgery with you so that you can be prepared for all that may entail as well. Because again, we never want to, the scenario to be that we're not prepared for, endometriosis on the bowel or rectum and have to call, intra-op consult. If we can plan all this ahead of time, that's always the best scenario. And then other situations where I may also refer to colorectal is if the MRI is showing dense adhesions between the rectum and the backside of the uterus. It may not always indicate that there's a nodule there, but if the rectum does appear to be stuck, it will need to be separated during surgery. So in order to do that, then I would need a colorectal surgeon to be able to do that safely. And sometimes we do find, even if the MRI is not showing a nodule, if there are adhesions, then there may be endometriosis still on the rectum that needs to be excised. Another criteria that I also use, and again, not everyone uses this, but if the MRI is also showing either a large endometrioma, which is a chocolate cyst on the ovary, or if it's showing endometriomas on both ovaries, then that may be an indication that there could also be bowel involvement, because endometriomas on both ovaries is a sign of more advanced, more stage 4 endometriosis. And with that, commonly we do find that the rectum can be involved in those situations, even if the MRI doesn't specifically indicate that. And so that may be another situation in which colorectal may be involved with surgery as well. Another thing that I also want to mention is that sometimes the MRI may indicate that there is a lot of adhesions from the report. And again, adhesions are hard to diagnose with 100% certainty on the MRI. A lot of it is kind of a gravity dependent position, the way you're laying when you're getting the MRI. If the rectum or the bowel is laying on the uterus, it could appear to be an adhesion and not be a true adhesion. And so that's why there's other things that the radiologist will look for in determining if this is a true adhesion or not. They'll look for, the planes between the tissues, things like that. All this to say that sometimes if the MRI does show that there's adhesions and we're being cautious and saying, hey, we should have colorectal involved, sometimes we may get into surgery and those adhesions aren't always found. And so again, it's always, my preference is to always be prepared and have the, colorectal surgeon or someone available in the event that there is more severe disease. Okay. And the last topic I want to discuss, and then I'll turn it over to Dr. Amin, is just the impact of endometriosis on fertility. And so we do know that endometriosis is associated with infertility, but not every woman who has endometriosis necessarily has infertility. And so about 30 to 50% of women with endometriosis may have infertility. And so there are different ways that endometriosis can impact your fertility. And so it may affect the fallopian tube. So if there is either blockage of the tubes or involvement of the tubes that affect the ability for the tubes to function properly, can also impact the ovaries or the ovarian reserve. So if you have a large endometrioma on the ovary, that could decrease your ovarian reserve, which is the overall number of eggs you may have in your ovaries as well. And then additionally, just endometriosis in the pelvic cavity causes this chronic inflammatory state, which also then results in inflammation, that kind of somewhat, I like to say, like a hostile environment for the oocyte and the for the egg and the sperm to meet for a successful pregnancy. So those are all things that are kind of taken into account when we're deciding whether or not endometriosis is affecting fertility. And I do get asked a lot, kind of what are the kind of fertility testing options that I can do, especially in patients who haven't necessarily tried to get pregnant, but they want to know if their fertility is being impacted by their endometriosis. And so there is one blood test that we can do. It's called the anti-Müllerian hormone, or the AMH. And so this will give you an idea of what your ovarian reserve is. And so there are certain values that we look for, which are considered to be within the normal range, and it is correlated with how old you are, because those things vary. So your AMH, or your ovarian reserve, is always going to steadily decrease over time as you get older. And so this value is useful information to know if there is any impact there. Again, ovarian reserve alone isn't the only thing that affects fertility, but it is an important piece to know moving forward. And then another test you can do is a hysterosalpingogram or chromotubation, which can be done at the time of surgery. These are both tests that are going to assess whether or not the fallopian tubes are open. And so a dye is injected into the uterus, and then we're looking to see if that dye then spills out the fallopian tubes. So these are ways to assess for your ovarian reserve and your tubal factor. Again, that's not the full piece and full picture of fertility, but those are two common things that are affected by endometriosis. And then lastly, there are patients may be candidates or may want to consider freezing their eggs to preserve their fertility. So for example, if I have a patient that's 23 years old and their ovarian reserve is already on the lower side and they have severe endometriosis, I may recommend either a consultation with the reproductive endocrinologist to at least discuss egg freezing, because even though you're not at the point in your life when you want to start building a family or having kids at 23, you may want to 5-6 years down the road, and at that point your AMH may be lower due to the chronic impact of both age and endometriosis on your ovarian reserve. And so considering egg freezing earlier on in life may preserve your fertility for the future. And then last part, big component, again, I'm not a reproductive endocrinologist. I personally do not do fertility treatments, but we do work a lot of times, with these specialists. And so typically there's different treatment options when you have infertility and if it's related to endometriosis. And so the really kind of gold standard, and I would say the best option, if feasible, is to do IVF with your excision surgery. Of course, there's also the option of just doing IVF alone or excision surgery alone, but really the two combined are proven to have the better of the two outcomes. But of course, IVF is not always an option for everybody. It can be expensive. And, again, everyone may not want to do IVF. That may not be, in the treatment plan for you. And so, again, if that is something to consider, we can always refer to fertility specialists. And then lastly, kind of how to approach your fertility in the future in someone who has endometriosis. Once you do start trying to get pregnant, typically in general, we say don't undergo a fertility workup until 1 year of trying to get pregnant. Well, in someone who has endometriosis, we're a little bit more aggressive in managing that sooner. So we would recommend after about 3 to 6 months of trying to conceive, if not able to get pregnant spontaneously, then that's a good time to start undergoing workup and meeting with that may be a good time to start undergoing workup and meeting with a fertility specialist, just to start discussing your options. Okay. All right, that is all I have from a gynecology perspective. I will turn it over to Dr. Amin now.
Hi, everyone. Well, I just wanted to say thank you firstly to Allison for helping us organize this talk, and obviously Dr. Thigpen as well. It's really a privilege to partner with gynecology and speak directly to the endometriosis community through the foundation. So thank you so much for your time. As Dr. Thigpen mentioned, my role is really involved mostly for stage 4 endometriosis when these implants are affecting the bowel. And just, a broader picture there, women can sometimes see up to 10 physicians before they're even diagnosed with endometriosis. So that just gives you an idea of how poorly understood endometriosis can be within the physician community and also the patient community as well. It's just not very well advertised or understood in the literature as well. And so it's really important that you're being seen by someone who can accurately diagnose this and then refer you to someone who can treat it as well properly. And those pictures you showed were just absolutely beautiful. I think those pictures paint 1,000 words. If you think of the inside of your body as an onion, there's this outer layer to every organ, and that's called the peritoneum, as Dr. Thigpen explained. And our job as surgeons is to peel off that outer layer without injuring the underlying layer or the layers underneath that outer layer of the onion, because that outer layer is really where the implants are. And sometimes, that can be a very tedious job based on where the implant is and what the underlying structures are to the peritoneum. And so, just the process here, when a patient is diagnosed with endometriosis, it may even be through the imaging or even a physical exam. The physical exam is so critical in our world. On my end, I do a rectal exam. And really, when I see a patient in clinic, I'm feeling for any nodules, any irregularity. Again, these are all vague words, but anything out of the ordinary that would lead me to believe that they have rectal involvement. And so if you think of the GI tract, we have our mouth, which leads to the feeding tube, the esophagus, the small intestine, and then my area of expertise, which is the large intestine. And we've got the colon and the rectum. So on our physical exam, we're really feeling only for the rectum. That's as far as we can go. And if there are lesions that are suspicious, then that may lead me to counsel patients on doing a preoperative colonoscopy, which is all part of surgical planning. So the best way that we can have a discussion with patients in terms of what is going to be done in surgery is through properly investigating how much endometriosis there is in one's body. And so sometimes that means after doing an initial consultation, also going through and doing other studies, not just only the MRI, but possibly a colonoscopy as well. And so when patients come into my clinic, they sometimes will say that I am having diarrhea or constipation or extreme pain on defecation, sometimes even bloody stools. And other non-specific symptoms include bloating, cramps, nausea, vomiting, just poor appetite, weight loss. But again, you can see that the symptoms can be very non-specific, not just always pain on defecation and bleeding, which is more, I think, diagnostic of endometriosis. And so when I see patients with those symptoms collectively, those, I'll have them go through doing a colonoscopy. And again, the reason for that colonoscopy is we want to know, is there an implant that is invading the outer layer of the colon and fully through all layers of the colon, and it's something that is a full thickness implant. The reason for that is because that information is just so telltaling. It means that one surgical approach may be more necessary or needed versus another. If the implants are very superficial and partial thickness, we can excise or shave these implants off of the bowel wall, and sometimes that may need to be repaired with suture. If the implant is more full thickness, and that means that we really are coring out a full thickness of the bowel wall, and definitely need to repair that because that's essentially a hole that we're making in the bowel. And sometimes these full thickness implants can be very small, and we're able to just do a core out excision and repair that bowel with suture. And other times the full thickness implant is just very large, where there's too much real estate on the bowel involved. We can't just core that out, and we actually have to do a full thickness resection and a reconnection, which you can see these are the needle moves from being least invasive surgery to more and more. And doing that preoperative colonoscopy really can help me understand how much work I may have to do in the operating room, which is helpful for a patient to know instead of not knowing that information and being surprised with the aftermath. But going back to the slide here, so I get a lot of patients asking, does the bowel pattern and quality of life improve after surgery once endometriosis is removed? And I think the answer to that is yes/maybe. So if these implants are on the rectum, on the colon, there's painful defecation, there's more severe symptoms. Once those implants are removed and a patient recovers from surgery, then yes, these symptoms will improve. However, if it's non-specific symptoms, possibly constipation, diarrhea, bloating, this may be multifactorial, not just endometriosis itself. And so patients may see somewhat of an improvement in that or not, based on, is this directly related to endometriosis, or are there other diagnoses playing a role here? And I think it's just important to realize that sometimes it's not the physical implant on the bowel that causes these symptoms. It may just be irritation, visceral irritation of the peritoneum, that outer layer of the organs, that just causes GI irritation and can cause patients to feel bloated or cramping, what have you. And so it's just all related to the context of what's going on in terms of how will I improve or what will I feel after surgery. I kind of went into this a little bit already. What type of bowel surgery is needed for endometriosis? So we mentioned a colonoscopy. Really, when we're concerned that there is bowel involvement, I really will recommend doing a preoperative colonoscopy, and that's so I can properly counsel my patients in terms of what surgery I may be performing. How can you prepare for a preoperative colonoscopy? Well, most women have not in this age group undergone a colonoscopy. And so this may be their first endoscopy. And so what we do is we try to coordinate the colonoscopy with surgery. For both, if there is concerns of GI involvement, a bowel prep will be needed. And that's that laxative that is not very well favored. It's a drink. And we have patients do that the day before their colonoscopy. They're on a clear liquid diet as they're taking the bowel prep. They have diarrhea. They completely evacuate the colon so that the following day, which is the day of the colonoscopy, we can go through with the camera. It's a 20 to 30-minute procedure under twilight anesthesia, so not general anesthesia. And we take a very good look at the colon. And I'm really looking at the left side of the colon quite closely, the rectum and the colon itself, to see if there are any full thickness implants. That's an implant invading from the outer layer all the way through the inner layer. And patients wake up after that 20-30-minute procedure pretty immediately, and we go over the findings of the colonoscopy. Now, if there are no implants that were noted, then that's the best news that there can be after a colonoscopy. And then the following day in surgery, we take again another close look, but now at the outer layer of the bowel to see if there's any partial thickness implant on the bowel. And if there isn't, that really is the best case scenario. Now, if there is a small implant just on the outer layer, again, we can sometimes remove that with just the shave excision and maintain the underlying layers of the bowel and just primarily repair that with suture. Now, if on the colonoscopy we find that full thickness implant, you can imagine that telling that to a patient is just so helpful, because I can let them know that unequivocally we will be doing bowel surgery, we will be removing an implant. You're probably going to have some sutures placed in your bowel there. And if the implant is just too big, then we may be removing part of your colon and putting it back together. I think when it comes to GI surgery, patients get afraid of having the bag. I think that word is thrown out there a lot, and it's an intimidating word, especially for a young woman trying to get pregnant or whatever the context for anybody for that matter. It's a huge change in quality of life. And that is such a rare thing that is done during surgery, even for stage 4 endometriosis. Not everybody with stage 4 endometriosis needs a bag. It is such a selective, I'd say less than 3% of our population. And we really push the envelope with doing that bag. I think that we are phenomenal as a group at Baylor Medicine, TCH, in doing what we do. I can't underscore enough. It is so important who you go to for your surgery, gynecology, colorectal, both. It's so important to have the surgery if you have bowel involvement done by someone who is not just a general surgeon, but also took that a step further and is board certified in colon and rectal surgery. And even as a colon and rectal surgeon, someone who sees endometriosis. Endometriosis is not like other types of diagnoses. It's not a cancer surgery. The type of surgery that's done doesn't need to be so aggressive as you would be in cancer surgery or other benign diseases. And so that approach surgically needs to be more tailored. But, just for the sake of mentioning, when we're doing bowel surgery more so on the rectum, sometimes when the surgery is just a very large surgery, a large amount of rectum is removed and we're reconnecting, we protect that connection with a bag. And again, that's just such a rare scenario and more than often not the case. Some other things, while we're there in the operating room, we take a very thorough look at all of the bowel, the small intestine, the appendix. If any of that has implants, if it looks inflamed, then we address it. We can, go ahead and remove the appendix, remove the implants on the bowel. I think we're fortunate here at TCH and Baylor to have the Da Vinci robot as a group. We all commit to this, from gynecology to colorectal. It is the most advanced form of laparoscopy. The optics, as you saw in that photo, are just, there is no comparison to laparoscopic surgery versus robot surgery in terms of identifying those implants. The implants can be so subtle, and so you really want the best magnification with the robot to identify that so that we can thereafter remove it. As a group here between gynecology and colorectal, we have a great relationship in that there is always a colorectal surgeon on call, no matter what day of the week. Whenever gynecology is in need of us, we really are attentive, and we try to be, so that way we can serve our patients to our best ability. Thank you.
Yeah, and just to kind of comment on that, it's very nice because certainly there are situations where we were not preparing for there to be endometriosis on the bowel or the rectum. And fortunately, Dr. Amin, or one of her partners, is always a phone call away and is always there to help and support us. All right. Well, I think that is at least what we had prepared to discuss. We can kind of transition to the Q&A now, if you guys like.
Great. Thank you so much. That was, sorry, I have an echo. Okay, sorry about that. I was on 2 devices, so I could see everything. Okay, thank you so much. That was really informative. There's a lot of information there. I know that people have questions about. One, I have a couple questions that I'd like to follow up with you all on before we transition over and discontinue the recording. So one thing that I heard that I think is really important to point out is So many times we see patients saying things like, well, I had a colonoscopy and the doctor said they didn't see anything, so I'm fine. And from what I'm hearing you say, Dr. Amin, is it's not a diagnostic tool. It is a surgery planning tool. And just because you don't see anything on the the colonoscopy, that doesn't mean that there's nothing wrong. It just means that you likely won't need to have a full bowel resection. Am I interpreting that correctly?
Yes, you are interpreting that correctly. And it's not always a diagnostic tool because not all implants invade fully through the colon. So when we do that colonoscopy, we are putting a camera through the bottom and taking a look only at the inside of the colon. So I can't see that outer layer of the colon. I can only see what's on the inside. If you think of your stomach on the inside, that is all you see with an endoscopy. So in this case, for the colonoscopy, we're only seeing the inside of the colon. We're only seeing implants that are full thickness, but you have to have, if you think about the book, Where is Waldo? When you're looking at the book, you kind of know what Waldo looks like, and you're trying to find him on that page. That's what a colonoscopy is like for endometriosis. As a colorectal surgeon, I know, as a colorectal surgeon who does endometriosis surgery, I know what endometriosis looks like on the colonoscopy. And so I have a very low threshold to say, okay, that is endometriosis unequivocally, and know what that looks like, because not all endoscopists will be able to pick up on that finding, because there is no red X marks the spot. It's a very subtle salmon colored pink implant on the bowel wall that you just have to have a high index of suspicion for. And so, when that colonoscopy is done and that implant is found, it's so informative for a patient, because I can say to them, we're going to be doing a resection of the bowel in some form, whether that's a full thickness, implant that's being removed and being cored out, or just a full-on resection where we staple one end of the bowel, another end, and we reconnect that together. So that is so informative versus, who knows, this is Pandora's box. Maybe we're doing some GI surgery, maybe not.
Right. Thank you for that. Did you have a clarification?
No, that was it.
Okay,
We had
I'm
the same
here
question.
with another board member, Etney Griggs. We had the
Yeah,
same question.
we had the same question.
So great. It's for planning, not ruling out. And the other piece you just mentioned was somebody who knows what they're looking for. And that's one of the benefits of having a team like the two of you who see endometriosis all the time is you can notice those subtle appearances of disease as opposed to somebody who's maybe not treating this day in and day out. And I know we had, that's something that comes up all the time. It came up in the chat today. It comes up in the Houston Facebook group is I had surgery with this doctor. I got no relief. I'm going to have another surgery.
Yeah.
What do I do? And that was, there was a question just now in the chat about that. What do I do with this, what I'm learning here? And I think the answer is that you find someone who's experienced, who has that level of experience that the two of you are talking about today.
Yes, yes. I'll give two examples, best and worst case scenario. Worst case first, did a colonoscopy on a woman, found a very large implant in the rectum, very low down, close to the anus. Immediately during the colonoscopy, I could see that this was going to be a problem. She's going to need a reconnection after the resection and a bag. And that clinic visit before surgery was just so helpful mentally, emotionally to her, to prepare herself for what recovery would be like. She would need a second stage operation to reverse that back. That is, the less than 3% scenario, worst case scenario there. Multiple other women who I've done colonoscopy on found no involvement, despite the MRI showing maybe adhesions, dense adhesions between the rectum and the vagina, no implants, and that was really nice, reassuring information to tell them we're likely not going to have to do aggressive GI surgery.
Great. Great. And if you're not available for a surgery, who else are people seeing?
as GI surgeons specifically, if I'm not available. So there are, in our group of colorectal surgeons, we have three, myself, Yesenia Rojas, Khalil, and Dr. Atif Iqbal. So there's three of us surgeons. Any day of the week, Monday through Friday, there is always one of us on call. No matter, if one person's on vacation or whatnot. And worst case scenario, if one of us is not around or is involved in another operation, we have general surgeons involved too. So there's always a surgeon on staff, but I'd say 90% of the time, it's one of us three involved in the case.
Great. Thank you so much. I know that we have a ton of questions popping up in the chat. Thank you so much for giving such an informative lecture, both of you. There's been so much great information here. I'm going to go ahead and pause the recording so that we can address those questions in the chat.